And with that, I would like to welcome the CEO of the Council of Governors, Ms. Mary Mwiti, to come and please start off the meeting with her welcome remarks.
Good morning, everyone. My name is Mary Mwiti. I'm the CEO of the Council of Governors, and allow me begin by appreciating each one of you for first accepting to join us during this devolution conference. That is a conference with a difference. I say this because this time round, as opposed to what has been for the last 8 years, the conversations this time round are led by partners. And for that reason, we thought that it's prudent that we listen to the voices of the masses so that as even policymakers go back and start doing their businesses, budgeting, policies and the like, then the voices of the people is heard. And I tend to believe that the conversations that have been from Monday to today are extremely very enriching. And I tend to believe if the policymakers and the leaders of this country would actually, for the first time, agree to implement those, then I tend to believe this country will be a country with a difference. I want to speak about this year's devolution conference theme and why we borrowed it. For People for Prosperity is a theme that was carefully selected by the Council of Governors, Secretariat, and of course the larger planning team, basically to address the inequities that has been in this country, the region and above, for the last 1 year. All of us, if you come from this country, you know what happened last year. And because of the erosion of public trust, because of the voices of masses to be included in policy-making, decision-making, and the like, we thought that would position devolution as a catalyst for equity, inclusion, and social justice. There is no country without the voices of the people. There is no country without exercising high levels of equity. And there is no country without ensuring that there is inclusivity across, from the youth, marginalized communities, persons with disability, and of course the citizens of Kenya. And that's why we thought this time round, we need to involve the stakeholders across the civil society, public institutions, government institutions, and each and every person that would love to make a difference and change in this country. And all the conversations have been extremely very progressive. Coming back to this side event that is extremely very important and critical to us, advancing human rights and social justice through assistive technology and rehabilitative services is not only actually a theme, but it's a live theme that CHAI has lived to do. We have partnered with CHAI for the last 13 years since the advent of devolution in ensuring that we shape the agenda of the health system in this country. CHAI has walked this journey with us, and the successes that we drive and publicize today, we can actually attest, if not in every paragraph, in every line of the support that CHAI has given to us. I will first start with the assistive devices that has really progressed in all the counties. They have been in the forefront of ensuring equity and inclusion, in ensuring that assistive devices reach to the most vulnerable and those desire that. It is a program that has been running, and as we speak right now, we have an 80 scale program that is running with ourselves and CHAI throughout the country and throughout the 47 counties to ensure that we advance this. If you look at the advancement and retraining and retooling the healthcare workers, they have been actually in the forefront through the pediatric specialist training that they have advanced for the last almost 7 years going. They have actually come up with a program that ensures that there is retraining and the retooling of the pediatrician, nurses, and all other health workers through a 2 years robust program so that we can equip them with the modern technology, we can equip them with the modern and emerging issues that are coming out in the country. And by so doing, I can attest that as once they go back to their counties, there's a lot of imparting of skills because we do a lot of M&E together with them to see the extent and to which those that were trained are able to pass the skills to these other people. And for that reason, that's why I said this is not only a theme, it is a live theme that they live to do and to ensure that they do that. The other program that we're running with CHAI that is extremely very personal to me. And when they came to me, we had a conversation of almost 2 hours, and we took a journey on a Ramka, looking at where we were. 13 years into doing devolution is not so long, and of course we have a lot of things to do. And during that time, there was a lot of maternal deaths and the like, and Chai came and asked, how can we reverse this trend? And of course, ensure as much as these health facilities are new, then what is it that we can do in the very smallest way to ensure that at least we reverse this cycle? And they came up with a program that we went to Uganda, a few counties on a Ramka training, and as a result of that, there was a commitment on a MPDSR, whereas 13 counties prescribed to it. And yesterday, Monday, there were celebrations across, and I would invite all of you to go to Homa Bay County Pavilion just to have a sight of what has happened. I want to confirm that for the 13 counties, there's usually every meeting every Tuesdays at 7 a.m. just to take track of where we are. And if there's a mother that was lost, there is actually all the doctors, every stakeholder to confirm the procedure, the process, and whether there were misses and gaps to ensure that we lost that mother. And I want to confirm as we are today, this is the 96th day in this county that we are in without a loss of a mother. Tunaweza wapigia makofi tafadhali. If you look at Kiambu, they were going 6 months without that. What we needed to do, and Rosemary, you need to take this, we were challenged on Monday that we do not only look at the side of the mother, but Ramka is all inclusive. We need to include now this deliberate attempt to ensure that we take track of every child lost. We said a mother's life lost is actually a whole generation lost. We want to commit again. Any child lost is actually 1 million lives lost, so that we are all inclusive and ensure that this is achieved. And in so doing, one of the resolutions that we came up with on Monday is to scale it up in the 47 counties. This is a commitment that the governors have given, and we are going to champion it at the Council of Governors because this program is coordinated at that center, and we will be inviting all stakeholders to partake of the same so that we can change the narrative and ensure safety of every mother that gives a life. When a mother walks into a maternity, one of the things that we expect is she comes out alive, and not alive, but with the other life that she has given out. And I think together we can be able to do that. If you look at the disability training, it is one of the things that we have deliberately and attempted to do with Chai, and this has gone a long way in giving life and sigh of relief even to persons with disability within ourselves. And I think this is something that all of us need to do. And if you look at the program, we've been able to go to the communities and, of course, advocate and reassure the parents that you need to bring out these children so that they can at least benefit from the few programs that there are and even the assistive devices that we are giving out. So this convening today is going to canvass issues around how we can be able to advance these assistive devices technology, and of course, looking at the other side, what are the misses and the hits? What is it that we can do differently? And what is it that we've done well that we can scale it up? And without much ado, I really want to welcome each and every panelist that has accepted to be part of this very rich conversation so that together we can shape the agenda in terms of the disability and, of course, rehabilitative devices and retraining of our health officers so that we can make a difference in the health sector. Asanteni sana na Mungu awabariki. Thank you.
Madam CEO actually mentioned that as a country, we work together with our stakeholders. And therefore, it's very important as we're talking about innovations and for rehabilitative and assistive technologies that we get our stakeholders on board to actually give us also their views and also to welcome us into this space as we're discussing it. And with that, I would like to now welcome Mr. Samson Waweru, the CEO of the Care Society for the Blind, to come and give us his opening remarks.
Thank you. Good morning. All protocols observed. It is a wonderful time to be speaking to you on this important conference, Devolution Conference, on the theme Advancing Human Rights through Assistive Technology and Provision of Rehabilitative Service. I work with Kenya Society for the Blind as the Executive Director, and the Kenya Society for the Blind is a statutory body that was established back in 1956 to assist government in the prevention and alleviation of blindness and to promote the education, rehabilitation, and the training of visually impaired persons. We come here at a time where the World Health Organization estimates that at least 15% of the global population are persons with disabilities. This means that in our country, close to 6 million or 7 million could be having a disability, only that they have not been identified and have not been put or given the appropriate assistive technology devices that could help them live dignified and independent lives. In the area of visual impairment, we work with partners in ensuring that we identify disabilities early, assess and place so that we can reduce the number of children who have attained school-going age, yet they are not in schools. And I'm happy to say over 10 years ago, that number was over 37,000 covering the visual impairment. But today, it is estimated at least 13,000 children who have attained school-going age with a visual disability have not yet been enrolled due to lack of early identification and lack of the appropriate assistive devices. So through the 80 scale project, we have worked to ensure that one, through the society and its many years and experience of supporting the education system and a program that we did in the Kenya Integrated Education Program, we would have the right 80 brought in, and this has enabled the schools to begin to support learners, giving them quality, affordable education with the right resources and materials. Assistive technology does not only mean that we take these devices to the schools and leave them just like that. It requires training of both the teachers and the support staff to continue ensuring that these devices are put into good use. And it also requires that we also provide regular repair and maintenance service so that these devices can still be used for many, many years. This is because assistive technology for the blind, for example, a pen, which is a braille machine, is costing over 150,000, while a normal pen could cost 15 shillings. So these kind of investments need to be protected by also ensuring that the maintenance and repair services are there and within reach, so that we also train more personnel in the ground to be able to be taking care of this. And I'm glad to observe that within the 80 scale project, we've been able to come up with curriculums to support repair and maintenance of 80 equipments and devices so that we can sustain the gains that have been met. Ladies and gentlemen, rehabilitation services in our country are also a huge catalyst of ensuring that persons who have acquired a disability or have been born with a disability continue to get dignified lives. At the Kenya Society for the Blind, we started as a disaster risk center that was rehabilitating the soldiers who had come blinded after the Second World War. We also got to get involved in the rehabilitation of over 2,000 persons who had lost their sight in the bomb blast 1998 disaster. And this led us to embark on a journey to begin the Center for Adaptive Technology, which ensures that any person who loses their sight, whether working or in school, can get rehabilitated within 6 months, know how to use technology, and go back to their areas of work and perform at the highest level that is expected of them. This is only not about giving people independence, but also restoring the dignity of these persons so that they can continue to engage in the socio-economic development of our nation. We need also to be cognizant of the fact that most of the 80 devices that we have in our country are not manufactured here and imported. And so within the projects that we are doing, we are embarking on an initiative to ensure that at least even our spectacles can be manufactured around, because uncorrected refractive errors remain a big challenge, yet it only requires addressing it with the right prescription of glasses to enable the clients be able to prevent them from going blind. And so the theme also today reminds us that the issues of persons with disabilities have really evolved, and the way we approach is not in a charity-based yet, but rather in a human rights approach, as testament by the disability bill that was ascended to on the 8th of May by His Excellency the President, as well as the National Disability Policy that was recently passed. So I wish to encourage all of us not to do disability inclusion just because it's a compliance issue, but rather to embed all the principles and the practices that will support communities with the inclusive development that encourages local ownership participation, so that persons with disabilities can come to the table and see themselves as partners and not beneficiary of the work that are going on. So this Devolution Conference also should give more opportunities for many organizations of and for persons with disabilities to work with county governments to enable them embed best policies and practices and match it with the real practical work of empowering persons with disabilities, so that they can also help in improving those counties economically. I want to thank the organizers, the COG, Clinton Health Access, our partners whom we've worked together in different projects to give more people with disabilities independence, dignity, and ensure quality of life is really uplifted. Thank you very much, and I wish you well as we continue reflecting on the gains made and what the future holds when it comes to rehabilitative services and appropriate assistive technology for our people and our citizens. God bless you.
Thank you very, very much, Mr. Samson Waweru. And I have to say, Mr. Waweru, you're a man after my own heart. The reason I say that is last year I was privileged to be part of a team that carried out an assessment called the State of the Healthcare Market in Kenya 2024 report. One of the major findings of that report was that out of the 2,000 non-pharmaceutical products used in healthcare, guess how much are manufactured in Kenya? 70. Out of 2,000 products, we manufacture only 70. I use glasses. Last time when I went for my prescription to be checked, to be redone, I had to get them from Italy. Glasses. Doesn't make sense. And that is a fantastic segue to our next presenter, Dr. Wako Ejesa, who is the CEO of KEMSA, the guys who actually purchase these things for us. And maybe one of the questions we are hoping to hear answered in his opening remarks is, what are we going to be doing as a country to actually make sure that what Mr. Samson Waweru mentioned having these technologies developed here in this country actually gets to happen. So, Mr. Oyoru, I'm sorry for putting you on the spot, but please welcome and give us your opening remarks.
Good morning. Mchangamke bana. Good morning. Yes, we have come here for a purpose. So to address some issues of grave concern as a country and put our heads together to make sure that there is equity, there is social justice, and that no one is left behind. So, Chairman, Daktari, all protocols observed, the CEO of Council of Governors, you know, she's required everywhere. So she had to go and attend another one, but she left her regards and her team are here. Everyone is here. So mine will be a very brief one, but I must say thank you to the CEO of the Kenya Society for the Blind for the words of encouragement and of course the conveners for bringing us here. So, ladies and gentlemen, you know the Constitution of Kenya 2010, the Persons with Disabilities Act of 2025, and the United Nations Convention on the Rights of Persons with Disabilities position assistive technology and rehabilitation as a human right. So when something is a right, it is not, you know, a routine thing that we gather here. We are coming here as human beings to address and say, how are we doing on this human rights issue? So as KEMSA, we recognize that inclusion must be systemic. That means making AT devices available, affordable, and accessible to all Kenyans who need them. So once you recognize by promulgation of the Constitution and the various acts that come from there, KEMSA has positioned itself and considered AT devices as you know, systemic approach. So our role in this journey is to ensure that the assistive devices reach every corner of the country reliably, efficiently, and sustainably. So, true to our mandate of all health products and technologies, including the assistive devices, we must make sure we reach the doorstep of every facility and every community that requires this service. So under the specific project of the AT Scale Initiative, KEMSA has been a lead implementing partner in shaping the AT products market and accelerating their access through an optimized supply chain. Additionally, we have worked closely with the Ministry of Health, the Council of Governors, you see all of us here, CHAI, the Clinton Health Access Initiative, and other partners to, one, standardize the specifications for assistive devices to streamline their procurement. So we must be able to make specifications so that we buy the right commodities. Then number two, we are partnering to strengthen procurement frameworks for steady supplies. So we don't want a touch and go. We want steady supplies, a systemic approach again. Number three, with that, integrate assistive products into the KEMSA LMIS, the Logistics Management Information System, for easier ordering by the counties and health facilities. So we have a very robust LMIS for health products and technologies. So we have to integrate the AT devices into the KMLS so that we are able to do a lot of things which I will address later. And of course, number four, we want to build capacity among our staffs to handle specialized AT products. So these are highly specialized products which we have to train our people in KEMSA, our teams in KEMSA to be able to handle. What are the progress so far? In terms of the wheelchairs, we have successfully distributed over 300 wheelchairs to 12 counties, and we are still going to support the mobility of persons with physical impairments. Hearing devices, we have delivered to the regional hubs newborn hearing screening equipment and audiometers, and already supporting early screening nationwide. So to get solutions early in life, we have those screening equipment already distributed to regional hubs across the country. The eyeglasses, a wide range of eyewear, including custom lenses, ready-to-clip glasses, and frames, are being procured and distributed through our national network. So we are relying on the vast network of KEMSA across the country to do these very important activities. In terms of infrastructural support, we have supported the operationalization of the optical labs and outlets, forming a hub and spoke model linked to lower level health facilities. Now, how do we embed the AT scale into the national supply systems? For sustainability, assistive technologies have now been integrated into our LMIS, as I earlier said, allowing ordering, real-time tracking, forecasting, and inventory management. So the logistics management information system is a very robust system that now allows facilities as low as the dispensaries and health centers, level 2, 3s, and 4s, and 5 and 6, to do the ordering, and real-time tracking of what is available through our LMIS. This integration into the LMIS allow us, one, to do accurate quantification of demand. What exactly do we need? The real numbers. It also helps us to know the stockouts and overstockings that we have so that we stock the right quantities, optimal levels for equity. And it also helps us in cost-efficient procurement and equitable distribution. This, LMIS, we will do selective KEMSA staff will receive specialized training in AT, logistics and management, enhancing internal technical capacity. So, in terms of county engagement, we realize devolution is the cornerstone of Kenya's health system. That one is not a doubt. And counties are extremely essential to scaling and sustaining the AT services. We can only facilitate the counties. They are the cornerstone. They are the service providers. They are where the rubber meets the road. And that's why COG is very strong here. Counties are very, very strong in this forum. We are actively engaging county governments to ensure that procurement and distribution of assistive products are responsive to local needs and informed by data. So we do not want to guess anymore. We need to use data, and that's why we have embedded all your services on behalf of all our partners into the LMIS, which gives us real-time data on all issues. County health supply chain teams are being supported, just like KEMSA teams, to work in synergy with the national teams for seamless last mile delivery. So KEMSA is very proud about last mile delivery. That's where we are strong, to position. I know partners may have the money, they may have the technology, but reaching the corners of every point of this country is mainly, I can say, a preserve for KEMSA, and we do that very well for all HPTs, now including the assistive technology. Now, in order to emphasize equity, efficiency, and social justice, which is the theme of this devolution conference, the AT Scale project is not just about products, it is about people. So we cannot proud ourselves by just saying we have this and that products. I think as my colleague CEO of KSB has said, we have to focus on people, human beings that require these services and products. This is about restoring mobility, enhancing communication, improving vision and hearing, and enabling independence and participation. how beautiful it is to do all this. That those with physical impairments, we enhance their mobility, we enhance the communication of those who have differently abled in terms of communication, and differently abled in vision and hearing. We enable all these Kenyans and enable independence and participation, full participation in their life's activities. Our goal at KEMSA is to ensure that no child, woman, man, or elderly person is left behind due to lack of access to a device that could transform their life. So we know how transformative to life these devices are through the 80 scale and other fronts. And as KEMSA, we will ensure that no one is left behind and that they can realize their full potential. We call upon all county governments, all the 47 county governments, to prioritize AT, assistive technology, in their health budgets and their procurement plans. So this is a rallying call to all counties to put this in their budgets and procurement plans. Number two, adopt the standardized specifications and data tools developed under AT scale to ensure proper forecasting and quantification is done for ATs. So we are trying, as stakeholders in the AT scale project space to make sure that we have the right specifications so that we buy the right things that can aid our people. And therefore, we are asking the counties to look at these standardized specifications and also monitoring tools, the data tools that have been developed for reporting, to ensure we have adequate and proper forecasting and quantification. So mine is to say a big thank you to all of you and for really this attention that you have given us. I thought I had some few last words. Yes, here it is. So we are also calling upon the counties to partner with us to identify gaps and improve last mile reach. So we are saying KEMSA is there for you. Please partner with us as you partner on the general HPTs, on the assistive technology devices. Partner with us to identify what gaps exist and how we can improve last mile reach, including integrated distribution. Together, we can build a supply system that serves everyone, especially the most marginalized. So our supply chain system must be able to empower everyone, everyone, including the most marginalized in terms of being differently abled. I want to thank the Ministry of Health for its leadership, the Council of Governors again for county-level coordination. I recognize the presence of Katra, who is the Director of Health. You can wave in the Council of Governors and the various teams. Thank you. Thank you for being here. They help us a lot in terms of county-level coordination. Our development partners for their sustained support. Chai, we recognize you. You are here. Thank you very much. And all development partners for the sustained support in this arena. I also acknowledge the voices and contributions of organizations of persons with disabilities who guide us in ensuring our systems are people-centered. So we don't talk to ourselves. We talk to the organizations of persons with disabilities to exactly know what are the needs, and we fix those needs together in the spirit of people-centered, people who matter approach. In conclusion, let us remember access to assistive technology is a matter of rights, dignity, and justice. It's not just a talk. It is a matter of rights. It's a right, people's dignity, and justice. At KEMSA, we remain fully committed to playing our part in building an inclusive health system that delivers for all of us. So I thank you very much, and I wish you fruitful discussions in the remaining bit of the program. Asante sana.
And I'm going to be inviting one of the main sponsors for this particular event, as well as a great partner for assistive technologies in Kenya, that is Clinton Health Access Initiative, represented here today by a personal friend of mine, Rosemary Kihoto, who is also the Deputy Country Director of CHAI. So, Rosemary, please welcome.
Good morning, friends. My name is Rosemary, as you've heard. I've been requested to actually set the stage for the panel conversations. I remember when I walked in, Dr. Marani asked me what I'm doing here. Because many people associate us with HIV, reproductive health, maternal, newborn child health matters. That's where we also make a lot of noise and we really support different areas. But on the other side of health, there are priorities, and health and other sectors, there are priorities that have lagged behind. I think I would use that word instead of neglected, but have lagged behind, and they're also tied to health. And we felt it was very important that we also apply equal support to this particular area, which is rehabilitation services and assistive technology. And I have a short presentation that I'm going to make. But very quickly, I can see there are many users of assistive technology devices. And maybe the question I would ask is, one, Catherine, can you share your glasses, for example, with Dr. Marani? If you swapped, would you be able to, right? It would be chaotic. Things would be different. You would see or you would not see. The same way, I don't know if we have anyone in the room who has, for example, hearing aids. Those cannot be shared with somebody else. And one thing we emphasize on in this space is appropriate availability of appropriate assistive technology. When we first started talking about even wheelchairs, people would say, but there are a lot of wheelchairs that we see people donating. But if you put a keen eye on those donations, many of them are actually mobility wheelchairs, which are meant to be used in hospitals to transport patients. So there is a huge lack of awareness. People mean well, there is sometimes resources that are available to us, but they are not applied to the right devices. And so our work began from creating awareness, the first from, teaching people about appropriate assistive technology, the different types of devices that are out there, and the different needs that they serve. And it is, as I said, an area that cuts across very many sectors in the Republic. We have the Director of Special Needs from the Ministry of Education. We partner with them because those kids who we are screening and offering these services to are actually in schools, somewhere in a boarding school in Moranga, in Kakamega, in Machakos, perhaps not without the right device. We partner with the Ministry of Gender, I believe, and Social Protection, the Department of Social Protection, because that is where disability sits. And without them, again, would not be able to make the inroads that we've made. I have a short video here.
At the same time, we're able to look at their strengths. Additionally, we are also screening for mobility assistive devices. That is, we are checking for whether a child requires any assistive devices that can help with mobility. And when they require those devices, we are able to do specific assessments pertaining to those different mobility assistive devices, for example, crutches and wheelchairs, amongst many, many others. In a case whereby a child already has an assistive device, we are checking whether that assistive device is appropriate for the child or whether it needs modification or a new one altogether. And once we do that, we are able to refer these children to the right kind of services and also for provision of assistive devices related to the mobility domain. Once we screen, we are able to provide basic interventions on site for the cases that do not really require further interventions. For example, splinting for upper limbs or the lower limbs. And then for the cases that require further attention, we are able to do proper referrals to the right kind of personnel for further interventions. For example, in my domain, we are referring a lot of the children to orthopedic technology, orthopedic surgery, physiotherapy, occupational therapy, special needs education, and many, many others.
So I think the whole purpose of that was to make us appreciate that just like the continuum of care we follow with other conditions, for example, in the health sector, you must screen appropriately with the right devices. You must arrive at a conclusion, isn't it? That this person fits into this category, and they require what would be the equivalent of treatment is the appropriate assistive technology. And so with that appreciation, the rehabilitation sector or services department is responsible for offering those services. In addition to that, after you arrive at a conclusion in terms of what your client has, you must offer an appropriate device, which again, unlike medicine or drugs that are off the shelf in a very predictable manner, majority of them actually have to be fabricated. You must send the prescription to the specialist who can prepare the wheelchairs to the specifications of a client. Just the same way your glasses have to go in to be fitted. Sometimes those places are not widely available. This was basically to remind us that in the Kenyan Constitution, all Kenyans have the rights that are listed in the Bill of Rights, remember? In addition to that, we have the Persons with Disabilities Act that I believe that the President assented to, and this is where the rights are centered. When we talk about assistive technology devices and their appropriateness, we're talking about different domains. We have mobility, this is where the wheelchairs fit in. We have the visual space, which is where the eyeglasses, the braille machines, the white canes fit in. We have the hearing domain, which is where the hearing aids fit in. We have a neurodivergent domain where we focus more on speech and language therapy. And these are some of the AT devices that we've been focusing on. In Kenya, we have more than 1.6 people living with disabilities. However, access to the services and the assistive technology devices is very low. Less than 20% of the 1.6 Kenyans who are living with disabilities have access to assistive technology devices. So there's a huge need in the country and we need to do more. Children, again, we have about, out of the 1.6, nearly maybe half of them are children, around 714,000 children. And the lack of assistive technology basically means that, especially for children, that their caregivers have to give up their daily livelihoods, isn't it? To take care of these children full time. So what that means is that you're in the house or you're in the home full time and you cannot engage in economic activity, which means again that that home or that household is likely to just cascade further into poverty. Children are not able to go to school, so not many can get an education from that. And so what we've done in the last 5 years or 6 years or so, we have set the foundation for offering these services. We have the policy and guidelines framework in place, the guidelines we need to prescribe, to procure, as you've heard from Dr. Wako's presentation. Those have been worked on and are in place. We have, on the service delivery end, established curricula to basically, as you heard, this is an area that has lagged behind, so we don't have a lot of the people we need to offer these services. When you think about audiologists, prosthetics, and even people who can fabricate the wheelchairs, we have very few. And so we started off by setting up the training programs in our institutions, also training a few people in our health, in our counties to begin offering the services. And as you can see, we have people in training, and there are some who have already been trained in the facilities, ready to offer the services. On the supply chain end, I don't want to repeat what Dr. Wako has said, but we have introduced wheelchairs, eyeglasses, hearing aids into the national supply chain system. Counties can set aside the budgets and begin ordering for these commodities from KEMSA. That first photo is actually our very first set of eyeglasses that were delivered in the KEMSA warehouses. We have wheelchairs in there. We have in 17 facilities introduced advanced and specialized hearing devices. Mombasa County is in the house. They are one of the beneficiaries, the national hospitals, so that we can begin screening our babies early and intervene before the first year. And for the hearing domain, it's particularly important so that, again, the interventions that are required are offered within that first year and going forward. And by the time they're ready to go to school, they've acquired either speech and language or have started learning sign language. This is just a demonstration of some of the work that has gone on. This is the optical lab at Kenyatta, where we can now offer the full cascade of services. You can have your eyes checked, you can get your prescription, and it can go to the lab, and at the end of the day, you can get your glasses, or in a few days, you can get your glasses. This lab is not specifically it's not only for Kenyatta, it's for any region that can access this lab for now. They will be ready to offer that service. We're going to set up another one, another 3 in Mombasa, in Nakuru, and in MTRH. And hopefully, as we continue to raise funding domestically and even outside, that we can expand to more of these facilities. This is our new state-of-the-art orthopedic workshop at Kenyatta National Hospital. This is where most of the prosthetic limbs are made for the country. And he'll tell the story of how limited they were. And so we've brought in efficiency, we've brought in new technologies that will enable them offer more people, more Kenyans this service at a shorter time. And we've trained for him people at KMTC so that he's well prepared to serve the country. And after this, hopefully, as we raise more funding, we can go to other regions. But nothing stops us from optimizing the service that Kenyatta has, because all you need to do is send a prescription, then connect to the council. The necessary waivers will be provided or funding, and the services can be offered. In addition to this, one particular area that is very important for children with disabilities is that they must play. However, today they don't play. They're lying in a hidden bedroom somewhere in a house. They are sometimes left outside, right, in a mat. Have you seen that image in the villages, in our estates, right? But it's because they don't have assistive technology. Now, once we give them assistive technology that they can move, they can see, they can hear maybe, they've learned sign language, they can communicate, then children will begin stepping out of the home to participate in a very critical part of our lives. If you remember very well, in our childhood, we probably spent 90% of our childhood playing, right? Many children with disabilities are not doing so. However, they cannot play with the toys that you're playing with or some of the games you played, right? Because of the impairments. And so we've adapted most of these toys to the specific disabilities. For visual, we've emphasized on touch, sound. That's for the children who are blind or who have low vision. For the one who can't hear, we've emphasized on visual and touch, because they can see, they can touch. And then, of course, for the neurodivergent, there's a communication aspect. But one thing to note is that they are universal. Any child with any disability can use any of these toys. We're using local carpenters, local organizations who've been doing small-scale stuff, and we're working in schools. With the Ministry of Education, we've extracted the recommendations from the national curriculum, because play is also integrated in our learning setup, and so we're introducing these tools in our schools, special needs schools, so that these children can learn through play, and that they can also play for their social schools and social skills, growth and development. We've reached quite a number of people since we set out on implementation. Over 3,000 people today have been reached or screened. There are assistive devices that we have actually given out, hearing aids, wheelchairs, partnering with many partners in the room and those who are not in the room. And I think our call to action, as it's been said before, our access still remains very low. So we need to aim for a nationwide scale up, reach more of our beneficiaries through our health facilities, through our schools, through our communities. We need a wider pool of healthcare workers who are specialized in the services that that are special to this particular program. We need our health facilities to set up the infrastructure that is required. As you've seen, it's not as easy as sitting a clinician in a consultation room and putting drugs in a pharmacy. There's a lot more. For example, for a facility that is offering wheelchair services, they need to set up a training space where you can teach the clients how to use the wheelchair on different terrains. Rough terrain, going down a ramp, going up where those facilities need to be set up. And of course, even the labs that we are talking about. We need adequate financing. As you've heard, we have a small catalytic donation across the devices, but that is not, for us to sustain this, our counties need to set aside resources to begin procuring the commodities. And then, of course, now, once everything has been set up, we need to go out into the communities and reach more Kenyans. As you heard, if we have less than 100,000 Kenyans who have access to these services, there is more than 1 million to reach. So that's our call to action. And I believe I've set the stage for the conversations that are happening. Thank you very much for listening, and looking forward to the next session with the panelists.
So we would like now to get to know some lessons and experiences in assistive technology across the counties. And we have two esteemed leaders in healthcare in Kenya today who will give us some of these lessons that have been learned. And I would like to take this opportunity then to invite Mary Mwaniki, who's the Director of Disability Affairs in Kirinyaga, for her to give us what lessons have been learned in terms of assistive technologies in the counties. Welcome, Madam.
Good morning. My name is Mary Mwaniki, as you've heard. I direct disability mainstreaming and participation in Kirinyaga County. And I am a proud member of ATSK and Chai, being a sub-county. And I'm happy to see the colleagues that we have worked with in this journey. Because when we talk about disability, we speak about it like it's too far from us. I would like you to go to this website, look at those categories, and position yourself. Because if you are not in it, then you are almost there, especially on the progressive chronic disorders. And so then when we talk about disability or assistive technology, let's talk about it like it is for us. Talk about it as if it is for yourself, not for other people. Having said that, allow me to refer you again to the disability policy. The disability policy on environmental and attitudinal barriers, 1.51 states, attitudes and practices embedded in cultural beliefs, taboos, rights, and religion create near unsurmountable obstacles to the participation of persons with disabilities in the social and cultural, whatever it is. Attitude is the societal belief that persons with disabilities are lesser beings or inferior to others. This negative attitude ultimately results in suffering and marginalization. Hence, with positive attitude towards persons with disabilities, they will be visualized as persons with disabilities and not the disability, laying emphasis on their personhood rather than the disability. It is necessary, therefore, to overcome these barriers through aggressive and effective public sensitization, rehabilitation, and habitation programs There comes CHAI and 80 scale. CHAI and 80 scale did not see our disabilities, but they saw potential in a population that maybe just facilitated to move, they can participate meaningfully in socio-economic life. They saw beyond the word disability and saw potential. And it is for this reason I would like to congratulate CHAI and the 80 scale for giving us this opportunity and for seeing beyond our disabilities and seeing potential in an untapped population. The 80 scale project has been a turning point, not just in how we talk and perceive assistive devices and technology, but in how we act. Because for far too long, assistive devices have been seen as optional extras or charity items. But with this project of CHAI and 80 scale, assistive devices and technologies are now a prescription intended to be fit for purpose and made to measure. Hence, to us, the persons with disabilities, they are tools of liberation, tools of access to education, to self-care, and to general participation in society. Because without them, then we are locked out of participation. And so then, in terms of human rights, I think I would say it is the right thing to do. That is what CHAI and 80 scale are doing. Allow me to mention that I met CHAI in Nanyuki, and they were gathering information or getting into the space of rehabilitative services. And this beautiful lady called Rosemary, if she had never had someone talk like a new radio with new batteries, then she had it that day. I couldn't believe that a huge partner or donor was getting into the space of disability, because most people look at other programs and not disability. For that, I thank CHAI, because they are the ones who initiated this process. And so then, through 80 scale and CHAI, we are witnessing a new order of doing things. It is not business as usual. It is not just giving a wheelchair. It is not just giving a hearing aid. It is giving something that will assist the person to participate meaningfully. It is not even business as usual for the process of doing that. Our healthcare workers have been trained. Guidelines, protocols, tools have been developed. And so then, it is not just doing it. It's a matter of doing it the right way. In Kirinyaga County, we have started initiating this process because it's a new order where even the people in the villages, they call and say, I want a wheelchair. And we tell them, no, go to the health center, have that wheelchair, have yourself assessed, have those people tell us what assistive device is appropriate. And then the aspect of demand generation, the aspect of assessment, the aspect of procurement, we are working closely with our healthcare system to ensure that this beautiful process is done right. We also have another challenge, reaching out to those people in the rural areas. And so then we are working with our health teams again to do reach out assessment programs in the rural areas so that then we go there as a team and have the people assessed from their localities. Because most of them, if we leave them out there, they don't have the capacity to get to our referral systems. And so then there comes another challenge again, the aspect of sensitization, creating awareness. Then change always comes with a push and pull. In most counties, disability is placed under gender and social services. But you realize in this aspect, health is a key player. And so then we have budgets in gender, but the main player is health. And that bringing that together is quite a bit of a push and pull, but we are almost there. And so then I'm sure in the counties, we must not give up. We have to make sure that that bit of mainstreaming this process is done and done right, because if we don't do it, then the aspect of getting inappropriate devices will go on, which is actually wrong. I can confirm that in Kirinyaga, we are already following the guidelines and the tools and the protocols to ensure that assistive devices and technology are supposed to be fit for purpose. Now, one of the things I value about this program is the fact that persons with disabilities were put on the table. Rosemary, I cannot thank you more that all of us, persons with disabilities, did not just sit on the table. Persons with disabilities themselves, who are the consumers, were involved from the word go. And so then in the subcommittees, we were able to bring our lived experiences and spaces in, because previously people would sit in boardrooms and decide for us. The process was technocratic, but for this one, it is all inclusion. It is all inclusion. And I can say this is what an inclusive process is all about, involving all of us, all manner of disabilities, to sit on the same table and deciding for ourselves. Now, as we move forward, we must challenge ourselves beyond pilot projects and just maybe relying on the partner who started the process. We need to move to full-scale national and county integration. Rosemary, we must push for the government and counties to put in adequate funding. Sometimes I find we have to keep lobbying for budgets for assistive devices and technologies. We must push for assistive devices and technologies to be included in the universal health coverage benefit package so that no one is left behind, because the potential is there. The barrier has been addressed. So it is now for all partners to come together and ensure that nobody is hindered by that barrier. I envision a future where policies across health, education, infrastructure, social protection speak the same language of inclusion so that we are not moving in silos. I also envision a future where locally manufactured assistive products are promoted and supported. I envision a future where partnerships with organizations for and with persons with disabilities are strengthened. A future where data collected is used not just for reporting, but for transforming lives. I envision a future, I dream of a future where the effects of the attitudinal barrier towards persons with disabilities is mitigated. Because with that barrier addressed, then it will be so easy to bring in more support systems, even more partners into this space so that together no one is left behind. Thank you.
You have to bear with me. As you have to be told, my name is Dr. Agnes Wawera Midamo. I'm actually a consultant pediatrician. My job is treating children. And staying where I am as a doctor can say I've got a lot of exposure and experiences when disability is concerned, not just with myself, but with also the clients I meet. In Nyeri County, where I work, I'm also in charge of the disability assessment program, where we assess people so that they can be registered by the National Council as people in disability. And now, in that position, I also find myself, when people come to me, they don't just want registration, they also asking me, where do I take my child? Where do I get an assistive technology? Where do I get this? And that is one thing I'm really grateful for Chai, because they have given me answers to all these problems. I cannot talk about disability without saying something very true about myself. Suffered polio when I was a baby, but as growing up, I could hear my parents asking themselves. I was a very valued child, so they were asked, what do we do with this girl? So mara wanasema, daktari amesema hii mguu ikatwe, waweke ingine. All those stories, and even in my young mind, I was find myself asking myself, if a leg is weak, does it really need to be cut? Anyway, eventually my father did his homework, and he finally landed what used to be called King George. And that is where my leg was not cut, but was fitted with the appropriate technology, which helps me to move around. And from there, because I got a bit of technology, I was also able to go to school. And that is why I can stand in front of you here today as a doctor, serving Kenyans and especially Kenyan children. Really grateful to technology about that. In the process, I got a chance to be educated in one of the special schools in the country, in Thika, Joytown School for People with Disability. One thing I noticed when I arrived there, I arrived working with my own technology made in the village, which was later changed. As the other colleagues came and reported to the school, everybody reported in their own way. Some crawling, some moving their buttocks, some moving their tummies. Very few had appropriate technology. But as we stayed there, things were done. Some of us were taken to hospitals, lives were straightened, joints which was contracted were straightened up, and we started moving in better way. So when Chai came into praise, my mind went back to how, when we arrived in Georgetown, how the lives of most of us were changed. The unfortunate thing about life, only very few of us go to Georgetown. The rest of the children in the village, the rest of the Kenyans in the village have nothing because there's nobody who's giving them anything. So when Chai came, I saw that dream when I seen in Joytown, where everybody in this country is going to benefit. And that's one thing I'm also very grateful for, because Chai opened doors which had been closed for many people in this country. One thing I would also add, and I know most of you know, disability and poverty tend to move together. I don't know which was causes one. Because when you are in a poverty situation, you are likely to get poor medical attention, so your disability is worsened. Again, when you get a disability, you are likely to have life and skills, so you're likely to be poor. So the two tend to move together, disability and poverty, poverty and disability. And Chai has come to bring equity. It doesn't matter whether you have money or not, you will get your appropriate technology. And I really find this a really useful place. And so for me, it's actually a personal excitement and achievement that what was dreamt of by many people in this country has come to be. The other thing I'm also very grateful for Chai, because sitting where I sit as a doctor, I see these things. Many children get late diagnosis for their disability because the technology for assessing this is not there. Some the disability, maybe they have poor vision, discovered very late. Some of them cannot hear. Even now when I'm doing the disability assessment, I'm brought children who are even 18 years old. And the parents, when you tell them to go for hearing assessment, one, because they are scared of cost, they tell, no, my child can hear, muite usikie. So you tried calling this child, you bang tables, the child is not responding. But eventually when you convince them to go for hearing assessment, which some of the machine is already provided by Chai in some facilities, then they are able to realize the child has not been speaking all along because they cannot hear. So this has enabled us to be able to make an early diagnosis on childhood disability, intervene early. And once you bring in technology, then you also are able to advise this person where to go for some education. And when give education, most of them will be able to earn their living, and this reduces poverty. I can stay here and talk a lot about the things they have done, the doors that they have opened, and I really hope they continue like that. When I was sitting there listening to KEMSA, and KEMSA talking how they are collaborating with Chai and receiving this facility and bringing them to our facilities, I started seeing a Kenya where disability means a different story. Because for a person with disability, if you change the beginning, you change the whole story. Because you open avenue for that person to be able to move through. And that is how you keep saying, Echo Chai, and may you continue and continue. And the other thing, as my friend is saying here, is Chai has involved us people in disability, because I see a slogan at the National Council for People with Disability, nothing about us without us. But things still continue being done without us being told anything. But Chai brought us on board to talk for ourselves, to tell them what we need, to tell them what we feel, and even to tell them what you know, what you have learned from experience about these devices. And I tell you, it feels so good when someone comes to you and asks you, what can I do for you? Rather than telling you, nimekuletea hii, tumia. When I'm asked, what do you need? Then I want it my way. Then I'm happy about it. If you brought me this wheelchair, My friend was here, Mary, she's a bit smaller than me. Then you tell me to sit on a wheelchair. It's not my size, but you come and tell you're he. So when you involve this person, it makes you feel worthy. It makes you feel wanted. It makes you feel appreciated. And that is what Chai has done for us. Because I'm begin few minutes, I want to tell Chai something also from the point of view of adoption. Some of the disabilities we have in this country can actually be prevented. Things like when I'm doing the assessment, almost 90% of the children assessed for disability are suffering from cerebral palsy. Cerebral palsy is a common problem, and most of these actually arise when you have complications during deliveries. And because Chai is also dealing with maternal health and child health, can we do something so that we reduce the number of cerebral palsy children in this country? Because if we assure safe deliveries, most of the cerebral palsy will go away. If we assure early intervention, most of the cerebral palsy will go away. I request Chai, beyond the technology, let's also practice a bit of preventive medicine, where reduce the number of disabilities in this country, where we can. We should also have a situation where instead of women just getting pregnant, can we also encourage our women to be getting ready for pregnancy? Because some of the problems that we call them neurotube defects, like the hydrocephalus, the spina bifida. See, some of these come because the mothers do not have enough nutrients in their bodies. So we can be making sure our women have their supplements so that they also get healthy babies. Chai, please, as you talk technology, let's also move a step, prevention of disability. Finally, as I conclude, I want to say something about this, please. Please allow me. I've been here since Tuesday, and I've gone through a lot of struggles. I don't know if some of you have noticed, if you have gone to the toilets, unapanda stairs. Have you noticed? Mukienda kwa choo munapanda stairs. So am I supposed to enter that toilet? I went there, and I felt whoever brought these toilets around did not think about us. Please, next up, this be considered. The other thing I notice is when you are walking around, you have to be specific. Like today when I came here, I wanted to enter through this door. And then nikapata hiyo mtaro hapo. So we go around, enter through the other side. And the other thing is entering, by the time you come and enter these gates in this facility, you have to go through many gates. Nobody wants you to pass there. They want you to come out. Anakwambia, toka utembe. So, me naenda and I make sure I'm showing my devices so that asiniambia nitoke nitembe. Because nobody considered that people in disability need to be given easy access to this place. For future organizer, let us think about that. Thank you very much.
I'm very lucky today personally because very few of the presenters here are not people who are not known to me. So I think I've just made a couple of new friends today as well. That being said, I would like to now welcome Dr. Oluga. How you became PS before me shows that there are a few marbles loose on my end, but karibu daktari.
Good morning, everyone. Yeah, thank you so much for having me here. And I do apologize for coming late because I have to juggle between plenaries and side events meant for my boss, the cabinet secretary, and those meant for me. And we don't have much excuses at the Ministry of Health now. We get everything done. But it's quite a great presentation that we've had from Dr. Midamo there. That's the one I've had. And I want to speak from the heart, not from these things. So in 2005, I was a medical student at Moi University. And there was a project that was assessing, there was a demographic survey on persons living with disability. And I happened to have been listed as one of the researchers. And I did the work in much of Western, from Webuye all the way to Kiminini, all the way to Matayos. Our then Professor Otsula had said that we do that. And it taught me a lot of things. Going to those communities, and we are going to the rural villages. And sometimes when I was leading this team, and whenever we got to a home where somebody had a person with disability, they would hide them, or people would run away. And we were doing an assessment, for example, children with cerebral palsy, persons that have had stroke before, all manner of disability, guys who for whatever morbidity had amputations. We were even doing mental health, disabilities. And it brought me to the reality of the level of stigma that are still in the society as far as disability is concerned. Fast forward to years later, when I was director at NMS, we increased the centers for assessments because of, that experience stuck with me. And so we increased the hospitals that were doing assessments. And we kept pushing, how can we make this faster? Because I used to be extremely disturbed by lines of persons that you could visibly see as abled differently, lining up for services. But something else was happening. I was on the 10th floor of Nyayo House, and on the 5th floor of Nyayo House is the Council for Persons Living with Disability. So I became their very good friend. And I used to go there a lot. But I saw sometimes the list of the people that have cards as living with disability, in my opinion, did not include these disturbing scenes that I've had in my whole life. And so I usually contend that out of the 900,000 people that we have registered in Kenya as having disability, I think there is a lot more in the community that we have not. And I think that's where I come from. Because even my own relatives, that for one reason or another had disability. It was until I was director of medical services in Nairobi that, they got to register after nearly 20 years of living with disability. And so they have been passed. So you can imagine if persons like ourselves still don't have that knowledge and the amount of stigma. So this list of people, near 1 million people, sometimes I feel it's driven by tax issues. I know, I don't think that there's a disability that you can say is less disability. But I would sign in my office, for example, those forms. And some of those forms you find, maybe it's just partial eyesight issues, or maybe just one place. But then because of sometimes people want the tax benefits, or sometimes people want the tender benefits, they are the ones who will be in the forefront. And I came to a statement which I made to my team in Nairobi that, this disability is like emergency care. Emergency care, when we are taught about coding for emergency care, the person who is nearest to you and shouting the most may not be the one that needs your care the most. And I think that's the first message I wanted to bring here as we talk about this 80 scale and the program. Because before we talk about assistive technology, we must have clarity on what are we assisting. What are you assisting? So I think we have not yet exhausted our survey for Kenyans who we should assist. Number two, one of the things that I expect this kind of forums to look at and to help us with is a comprehensive suite of what assistive technology should be. Let me shock you that in the whole country today, we don't have rehabilitation hospital. The whole country. We have a number of rehabilitations on the drug side, but rehabilitation, people who come from cardiac surgeries, who come from stroke, get discharged from hospital when now the medical therapy has been determined, there's nowhere that they go. There's no half place between the hospital. That's how far work we have to do. So my brother, bado kuna kazi. Now, I know that we've done quite a bit of work, especially on the 80 scale project. And there's been a lot of progress courtesy of this collaboration between ourselves and the county governments supported by CHAI. And there is progress. We have to mention that there is progress, even though it's not as much as we would want to report. We've distributed devices. We've done a bit of training, even though I suspect the training that we have been doing needs to be training across the entire health workforce, not just for specific specialties, even though it's still important to train on those specific specialties. I know the Kenya Medical Training College is here. There have been a number of scholarships, and there are a lot of our health workers from the county governments that have benefited. As we move forward, two things are key. One is the awareness around disability and the awareness around assistive technology. Because I think we have not yet exhausted the comprehensive list of what assistive technology is, and match it with our healthcare system and our context on what exactly should we do to assist. I think there is still a lot of work there. But number two is the financing. Everything about healthcare falls and rises on the financing. That is assuming that your governance and your structure is already okay. And so the financing of assistive technology. Under the Social Health Authority benefits package, I know a number of things are already covered. For example, I think eyeglasses are covered. There is prostheses that have been covered, wheelchairs that have been covered. There is more that can be done. But for us to do it, we need to resource mobilize. And so as we speak in these rooms, and as we make plans for what we are going to do, we cannot leave behind the money. And the money means that we get out of here and tell Kenyans to register for the Social Health Authority and to contribute to the Social Health Insurance Fund. We were with Katra when we were discussing the issues around maternal mortality, neonatal mortality. Some of you were there. And it's the same message I have across board. whether I'm meeting persons that are living with disability or persons that are living with HIV, or I'm living persons who have survived cancer, or I'm meeting with the diabetic patients group. The whole story is about money. Money is limited. So how do we, number one, prioritize what we are discussing here? But number two, how do we make sure that we have money to resource it? Right now, the funding landscape has changed, and I think you know that. Chai is supporting us for now. We've distributed a few materials, but you will need money in those hospitals to now purchase those things in KEMSA. You will not purchase them if they can't be reimbursed. You cannot be reimbursed if we don't have enough money to improve the benefit package. We will not have enough money to improve the benefit package if Kenyans do not register with the Social Health Authority and contribute to the Social Health Insurance Fund. And so in our discussions, financing is very key. And money does not grow on trees. Money comes from us. You know, there are only two ways that the healthcare system is financed. One is through the taxes, which you can also agree with the government that they increase your taxes and we take the money from there. You know, this is a consensus. Or that those of us that have a bit more, we contribute. We have a mixed model. So we are financing our primary healthcare, we are financing our emergency, chronic and critical illness through the taxes. But we are also financing a side of healthcare through the contributions. And that's really the game changer. Because if you want to fill the gap that has been left with the donor withdrawals, if you want to fill the gap of 35% of our healthcare system that is financed through partners, we must contribute. Now, contributions alone will not solve the problem we have here today. So we must also figure out what exactly in our healthcare system is so important that it must be financed with the little money that we contribute. The case that we have to make, and now I will at least lower my gear a bit as a PS and now speak to you as advocates. The case that you have to make on assistive technology is the contribution to the economy. That's the case that we have to make. Because when we consider what to pay for under the Social Health Authority, two things are very important. Number one, what is it that kills Kenyans? Number two, what is it that makes Kenyans poorer? Now, in what is it that makes Kenyans poorer, I think we may have a case to look at the economic contribution of persons living with disability if they are not assisted, or the economic contribution that they would make if they were assisted. And I think that's an urgent case when you're talking about the political economy, because politics is about the distribution of resources on where it matters. I think that's the case that we have to make as advocates and as people who are convinced, because I know everyone in this room is the choir. The people you need to speak to are not in this room. Personally, I'm part of the choir. So we have to make that case together. And that is also work that we have to do. And that's the assignment that I'll leave you with. But I'll finish by talking about everything that we do must align with the government priorities. Healthcare right now is one of the 5 key priorities for economic transformation. That's why I was talking about the economic case is important. Now, under healthcare, which we are racing towards the universal health coverage by 2030, and for which we have modeled our UHC based on tax funding, and contribution, which we are calling Taifa Care. The UHC model that we are pursuing is what we are calling Taifa Care. We have 4 key priority areas. One of them I've talked about, health financing. Now, the health financing architecture for our country has been for a long time exclusive and not equitable and not sustainable. And on this particular one, increasing the domestic resource is very important. Number one, Kenya was rebased in 2021 as a lower middle income economy. So if we go with a begging bowl to another country, we don't get as much money. You don't even get money at all. Number two is that everyone is now looking inward, and you can't get mad at somebody else's money. So if America says they don't want to give you money, you can't get mad at them. You go sort out your problem. So for us to achieve resilience, we must have our own pot of money. Now, our own pot of money cannot come from somewhere like manna dropping. It must come from the citizens. It must come from us. And that's why this conversation about the Social Health Authority is imperative. It can't be postponed. I think that I have talked about. But number two is that we must establish the mechanism that makes the healthcare system perform. The healthcare system must deliver the services that you want to pay for. And the whole of service delivery components that we think are very important, health workforce, the capacity of the healthcare workforce to diagnose and correctly give intervention, to be fit for purpose, including what we are discussing, to engage, to create that awareness, to have that awareness of assistive technology, because there are so many healthcare workers that are not capable of prescribing any assistive technology. So many. So even before we talk about the populations, we have to improve the capacity of the health workforce to be able to know what is it that you want to assist, to be able to even diagnose disability, because we have also made the diagnosis and the assessment for disability somewhat exclusive. I think we've made it somewhat exclusive so that the access to it in itself, even with the increase of the centers, is still a challenge for many people who require that service. The capacity of the health workforce is very important. The health workforce is the bloodstream of the healthcare system. Without it, all investments are null, void, and invalid. You can have all the CT scans that you want. You can have everything, including the money to pay for it. It's like a hotel. You have the money, but if the hotel does not have the tea, you can't pay for the tea. So we must have the people who make the tea, because in healthcare, the factory produces a service, and the service is the interaction between the health worker and the person seeking the service. That interaction, that is the service. That interaction must be of good experience and good outcome. So the health workforce is a very key component of what we must pursue, including for this room. So as we focus, and I'm glad that part of what we are doing here is to train, but there's more that we can do about that. Number three is the tools that the health workers need to deliver the service, the health products and technology, and the commodity security. I'm glad KEMSA is in this room. I think we've worked very hard to improve what we call order fill rates for county governments. We now want to work very hard to put some of these products, assistive technology products, in KEMSA. But the demand must be there so that we put these products there. Now, in the health products and technology, and particularly on commodity security, we must also look at our resilience, which means local manufacturing or local assembly. So as we discuss this assistive technology, wheelchairs, walking canes, specs, all of them, hearing devices, we must also discuss, where are these things manufactured? Why don't we make them here? Because we have to make them here so that then we reduce the cost, we create jobs, we can determine our own money. And I think this is a conversation worth your time. The last bit is the digitization. I've just mentioned the horror stories of people in communities that are still hiding their relatives and loved ones who are having one or the other form of disability. Now, these people have interacted with the healthcare system at some point. Were they captured? Perhaps yes. Was that data ever submitted? Maybe no. If we digitize the healthcare system and we unify it, then even the issue around assessment will no longer arise, because we will know that Dr. Luga went to a hospital, he had a stroke, he has now a permanent disability, or he has had an amputation, or he has had a visual loss, because the data has been captured. So if we segregate and analyze that data, then we will also be having what we call universal access to this assessment. And that's why digitization of our healthcare system is very important. But it's also important for two other reasons. One is the efficiency that we want to gain. And number two, so that the data that we have is reproducible. It's data that you cannot deny. It's data that if Dr. Marani wants to be the PS next time, the decision that I make is the same decision that he will make, because it's relying on the same information. And so those key priority areas, 4 of them: 1, health financing; 2, human resources for health; 3, health products and technology and commodity security that comes with it; and number 4, digitization, are very key for us. As you discuss, you have to align with that government agenda. And that's the last thing that I wanted to mention. So I think what we are discussing here is very important. We are assured, at least from our end, that we take this work seriously. And we will do everything that we can to progressively increase the services, to progressively increase the access, and to progressively increase the technologies that we need to enable our loved ones live fulfilling lives. But on the other end, as advocates, you have to give us the case for the economy. Not that we don't know, but sometimes these things are unified. You have to document it. It has to be evidence-based. It has to be practical. It has to be sustainable. And I look forward to receiving such reports and suggestions from you. Thank you so much.
Daktari, thank you very much for your words of wisdom. And we definitely hope that this panel will take, this group will take some of the advice you've given us into consideration. Now, if you look at your program, we had a photo session that has to be done just after this particular speech. So I'm going to ask the team that is doing the photography, if you could just quickly organize us. I propose that we just have it in front here. And I'm going to ask all the panelists who are on the program to come in front so that we can have a quick photo session with you.
I want to welcome our panelists. And today the discussion will focus on innovations shaping rehabilitation, the progress we've made and the challenges. So the first panelist I want to call on stage is Director Katra Ali, who's the Health Director at the Council of Governors. Please clap for Katra, she comes in front. Yeah, the second panelist I want to call is Mr. Frederick Haga, who is the Director, Special Needs at the Ministry of Education. And Mr. Haga has led efforts to ensure quality, inclusive learning for children with disabilities across Kenya. So please clap for him. And next is Mr. John Kabuchi, who is the Strategic Partnerships and Resource Mobilization, who works at the Strategic Partnerships and Resource Mobilization at KEMSA, and with several years of experience in supply chain management. Next is Dr. Shem Pata, who's the Chief Officer for the Medical Services at the County Government of Mombasa. And today he'll be sharing with us, from a practical perspective, the impact that AT-Scale has had in Mombasa County. Please clap for him. Yeah, next is David Monyendo, who's the CEO for Christian Blind Mission. David, where are you? Oh, David is already here. Yeah. We also have Dr. Lillian Moko, who's the neuro-otologist and cochlear implant surgeon, and is the head of surgery at the Kenyatta University Teaching and Referral Hospital. Dr. Moko, welcome. Then we have Mr. John Ondiege, who's a consultant, orthotist, and prosthetist, and also the head of the orthopedic unit at KNH. Welcome, Mr. Ondiege. And lastly, we have Mr. Nixon Kakiri, who's the president of the Kenya National Association of the Deaf and the founder of the Mixon Kakiri Foundation. So I'll request you wait for Mr. Kakiri to sit, then we can clap for him. Thank you. So we'll go direct into the panel, into the questions, into the panel discussion. And we'd like to start with Director Katra Ali from the COG. And the question is, Katra, what is your call to action for counties, partners, and policymakers here at the Devolution Conference when it comes to strengthening rehabilitation and assistive technology services across Kenya?
Thank you so much, Daktari. I thought that could have been the last question, but we can have that call for action. For us as COG, we always advocate for all population in this country. Every Kenyan must access healthcare, regardless of where you come from and who you are. And it has to be accessible, and we want to reach to everyone. First of all, let me apologize to the lady who has just spoken about the last speaker who spoke, the lady, in terms of assistive devices and accessing facilities within DEFCON. I know as COG, we've actually put that in place. Probably the signage and the direction will have not been properly done, but we take note of that and apologies for anything that has happened, and we are sorry for really what has happened to you. So in terms of what you've asked is, for us, we feel that we need to integrate rehabilitative services in all services that is offered in healthcare. And already we are doing that. And I know there was a directive some years back that when, for example, like you find somebody who has a disability, he cannot, as much as you want to come to a facility, you cannot be able to access services the right time because of some obstacles. And I know we've tried to streamline some of the needs that is required for a disabled person to basically access those health facilities. So what we are just advocating for is to ensure that we integrate rehabilitative services into all services so that we encourage everybody to make sure that they've accessed. And then the other thing is we really need to invest in infrastructure and workforce. And I know CHA is doing a lot in regards to that. We used to have a lot of challenges, even in terms of sign languages for people who access healthcare. Like the workforce gap was basically there, and we had a lot of challenges. Right now, when you go to facilities, you can be able to be helped if probably you require sign language, if you require anything. And we really give our disability access a priority. Like you basically don't even line up if you have an issue or if you want a medical attention. They are basically given high priority. They don't need to queue in the line. So what we are just saying is you need to invest heavily in all the infrastructure that is required, and basically do a lot of capacity building and training also for the healthcare workers so that they can be able to understand what they are expected to do for this category. Then strengthening also multi-sectoral collaboration, we need to basically foster partnership between counties, national government, civil societies, and private sectors to basically enhance access to innovative rehabilitative services. I know the role of national government is very clear and the role of county government is very clear. That is actually explained in the Schedule 4 of the Constitution. So as much as there are so many policies that are also developed at the national government, I think we need also to have an abridged version, which is so simple that everybody can be able to read and understand. So for the county government, what we are required also is to basically implement that policy guidelines or what has been developed. That way we can be able to move together. Sometimes you find a very good policy has been developed, but the challenge is the implementation. Why the implementation? Because there's a disconnect between the two levels of government. We don't talk to each other. The policies are there, disseminations have not been done well, so it has been missed out. So that is one of the things I'll really encourage for us to work together, and also encourage the partners to basically pull their resources together. You may find so many partners within this space, but they are doing duplication in terms of providing these disability services or supporting the services itself. I think if we can be able to pool our resources together, we can maximize the effort and we can make a bigger impact, unlike what we are currently doing, because we are doing things in silos. You may find 5 partners in eyesight probably doing the same thing. And then you may find also, in terms of equity, most partners are so much concentrated in certain regions, unlike other regions. But what we are saying is like all these services are required across all the 47 county government. So how can we map out and how can we work together so that we maximize the resources that are available within the space? The other thing I really want us to talk about is how can we be able to also collaborate with our partners and give them our priorities, because partners also come with their own priorities. For the counties, what we are required is like we need to budget and plan for these particular services. But as much as we are doing that, we are also working closely with partners who also want to support. So as we develop our county integration development plan, we know we may say like 15% or 20% need to go this way, but because we have other more funding from also the partners who are coming in, but the partners are also coming with their priorities. So how can we also be able to align? How can we be able to align our priorities and know that at least this is what we require? We can work together and we can be able to make an impact instead of actually doing a silo, or instead of putting it like a push. Because like you can come to a county and say, this is what I have and this is what we need to do. But that is not the priority need of the person whom I'm actually serving. So I think we need also to talk together. We need to pull our resources together. We need also to align our priorities. For county government, I know 30% of the total budget of health actually goes to health. And if probably, I know we are going to have a plenary after this, if probably you feel that there are more things that we need to do also, we welcome, you can be able to tell us. But I always say this particular theme for today is our priority, and we are ready to work, and we are ready to make an impact, and we are really need to support to ensure that access of healthcare is across all board. Thank you.
Next, I want to ask Mr. Frederick Hager from the Ministry of Education. How is the Ministry of Education ensuring that inclusive education is aligned with assistive technology provision, and what policy mechanisms are in place or required to embed ATs within special needs education planning and budgeting?
It is the business of the Ministry of Education to ensure that that constitutional provision of basic education as a fundamental right is realized by all children and learners in the country. And that cannot happen for children with disabilities if assistive devices and technologies are not provided. And so in the enabling laws and policy framework that exist, starting from the Basic Education Act of 2013 and the sector policy for learners and trainees with disability of 2018, assistive technology, assistive devices is provided for. And in the recent ministry's plan, strategic plan of 2023 to 2028, a lot has been highlighted on the provision of assistive technology and devices in our country. So what the ministry has been doing for the last 2 or 3 years, there is a budget that goes under the description of specialized learning resources and assistive devices and technologies that is sent or designated specifically for assistive technology and devices. And while this was happening even earlier, we established that the cost of devices and technologies was much higher than what the schools were receiving. And so for the last 2 years, we have been pooling the resources through the Kenya Institute of Special Education, and we have planned about a 3-phase step that will make sure that after 3 years, most of the learners at least have the basic technologies or devices that they would require to access education. Only then can we talk about access, quality, and relevance. Beyond that particular allocation that is annual, the ministry in its projects and programs that are supported by major multilateral partners like the World Bank have always included a component of the provision of assistive devices and technologies in the areas where those particular interventions focus. Allow me to mention the Secondary Education Quality Improvement Project, SEQIP, which focused on 110 sub-counties in this country in 30 counties. That project ended last year, but from this year, we are having a new one that builds onto that, and at least this one is going to focus on all the counties of the country. And we are ensuring that both at all levels of education, although this one specifically focuses on senior school, pre-vocational and junior school, and vocational and senior school, that those particular levels are going to be serviced. But as they say in economics, there are usually little resources trying to satisfy very unlimited wants and needs. So that by itself may not be adequate. And that's why the ministry also partners both with the governmental institutions and non-governmental players. In the government, we have learners who benefit from the devices and the technologies that are provided by the National Council. And currently, the ministry through the Kenya Institute for the Blind and with funding from the Communications Authority of Kenya has an intervention that targets learners who require technology because of their print disabilities. But beyond those agencies that are governmental in nature, we get a lot of support from partners. And the ministry has clear policy that guides its working relationships with the different partners. And I could mention the Clinton Health Access Initiative here because it's one of the partners that the ministry has worked with in terms of providing for these technologies and devices. And there are lots of other partners whom we do work with. Some of them are represented here. But to bridge that gap where the ministry is not able to fully meet the needs, we talk to our partners and we work with them to ensure that the devices are actually and the technology is available to the learners, especially right from primary to senior school or secondary. Again, the ministry working with the Kenya Institute of Special Education conducts functional educational assessment for the learners. And we have established that whatever is being provided is not exactly adequate because, like the previous speakers have pointed out, each individual person would require his or her technology. And sometimes some of this can be quite costly. We try as much as possible to use what's affordable, but that cost sometimes makes it difficult for the ministry to ensure or guarantee that all learners who require these technologies get them at the right time so that they're able to continue with education. But we also do know that the capacity of conducting some of these functional assessments that would lead to getting clearly the specific intervention in terms of technology that is required. Yeah, there are some areas where that is wanting. And that's why, as a ministry, we are also empowering the assessment centers. And in our World Bank funded project, we are going to be revamping some of our assessment centers at the regional level. Thank you.
Yeah, thank you. Thank you very much, Mr. Haga. My next question will go to Mr. Kakiri. And the question is, from your experience advocating for the rights of persons with hearing impairment, what must Kenya do to strengthen early hearing screening, timely interventions, and inclusive education for children who are deaf or hard of hearing? How can we ensure that assistive technologies such as hearing aids and captioning tools are accessible and affordable to all who need them? Yeah.
So far, we have had a lot of vulnerabilities at an early phase. So we need intervention programs when we focus on persons who are deaf. For instance, you will find that about 90% of deaf children are sired from the hearing families. So most of the times, members of the hearing, who are family members, do not know sign language. Thereby, the deaf lack a foundational language, and they lag behind whenever they attend schooling. So education becomes a problem. So they lag behind. So maybe at the age of 10, when you are actually supposed to have learned sign language between the ages of 5, that is the time when you start learning sign language. So your capability of succeeding in future becomes problematic. So what happens here is that at the hospital, the center, whereby we should be having early, diagnosis or screening to find out the needs of the person, whether they need a hearing aid, which type of hearing aid do they need, because you see, they cannot just choose any. And also, they are supposed to be using sign language. So the parents themselves are supposed to learn sign languages so that they can use it to communicate with the deaf children. And also, when you report to college, hospitals, and other facilities, you find that when you talk of assistive technology, you see, it poses a lot of impact in deaf education. We are now talking about inclusive education. Most of the times, whenever you go to schools, you find that the deaf children are maybe put as a group, clustered in a group or units. So maybe class 1, class 2, class 3, someone is in class 1, class 2, and class 3 that mixed together in the same class, as opposed to the hearing who are clustered according to their different grades that they have. So you find that accessibility is a problem because of that. So there is also a lot of policy needs that we need to follow up to ensure that we specify where it fits into them so that training can be good. It begins at the family level, and also the teachers who teach the deaf are also supposed to be service providers and supposed to be sufficiently exposed so that they can teach. So yesterday we closed a conference. We had the World Federation of the Deaf conference. We were talking about AI, artificial intelligence, in the use of sign language, because we have had some discoveries and happenings recently whereby technology is integrated. You'll find that the innovation is good. However, how inclusive were persons with disabilities, or rather the deaf people involved at the inception phase or rather at the design phase when the innovations were brought about to capture the actual truths and the needs of the deaf. The AI that I've seen most of the times, the human beings relies on touch, and it does not capture really the expressions. So we need to see how we can work together so that we have, targeted, at CHAI, you work more, focuses on maybe persons with disabilities organizations. So when at the design phase, we need to develop a training program. And I appreciate when you say that from during inception, we have been working closely with CHAI, and we're coming up with a curriculum or other program that will ensure that we are going to implement for the deaf people themselves. And we have also found out that so far, we have trained 70 health workers. We're at phase 1, and right now we hope to conduct more training across the other remaining counties. Yeah. So we are going to approach others, and we are encouraging more of this work so that we become inclusive in this process as we talk of screening.
Thank you very much, Mr. Kakiri. And still on hearing, I'd like to ask a question to Dr. Moko, but now from the clinical side. And Dr. Moko, given your experience in hearing care and leadership in surgical services at Kenyatta University Teaching, Referral and Research Hospital, how can Kenya accelerate early hearing screening and interventions at all levels of care? And what specific policy reforms or investments are needed to mainstream newborn and childhood hearing screening in line with the National Rehabilitation Strategy?
I'd like to approach this in a simple way, not very technical. Think about someone who is born deaf. So when you're born deaf, what happens is that you can either be born deaf or you are born with a certain level of hearing. And what happens is that some of these individuals, as has been rightfully said, they are missed at birth. So by the time they get to school or they get to the age where they are speaking, they have missed out their language, they are behind. And so we find that it is already too late sometimes to intervene and to help them. So we are looking at developing a life course approach where we work with our people from birth. We are able to look at how many children are born, and of those who are born, how many are deaf, so that we can be able to start the journey with them. For those who are born hearing, we are also looking at trying to look at the different stages of life which you are at risk as developing hearing loss. And that is mainly during the early childhood. So we are developing policies for early childhood education, screening in those sectors in the schools to identify children who might be having ear infections and other conditions that, such as measles and mumps, and treatment that exposes children to deafness, such as treatment for malaria, in order to be able to catch them early enough and rehabilitate them. 60% of children who are deaf are said to have suffered deafness from preventable causes. And so we want to also empower the teachers and empower the parents and the mothers from birth so that they can be able to know what could make my child become deaf and what could predispose this child and what can we do to support this child. Moving on to adolescents and young adults, we have a lot of noise-induced hearing loss in our jua kalis. We have noise-induced hearing loss from use of personal listening devices, such as earphones. This is another population that is at risk. So we want to also empower both the parents and the community so that they are able to talk to these children. We are able to also educate them and know the dangers of listening to music in high volumes, using personal listening devices for a long time, so that we eventually are able to create a generation of people who are able to take care of their hearing health well. Because even if you're born with good hearing, as you grow older, your level of hearing deteriorates, so that we can have populations who are healthier for longer. And finally, the people in our hospitals. We have 3 main non-communicable diseases that predispose our population to hearing loss, and that is diabetes. We have cancer, from both cancer treatment and the cancer itself, and we also have others such as hypertension. So these are populations of people who are at risk. They are being seen in our hospitals. So we are planning on how to empower the health workers to be able to screen and identify these people early enough, to be able to educate them, because they are becoming a greater majority of our communities. If you look at the Kenya Demographic Health Survey report of 2021, you find that 20%, up to 20% of adults who are 50 years and above, they say or they reported to have complaints of hearing or hearing complaints. So that tells you that we have a very large population of people who need to be made aware and who need to be screened. And so we are talking about screening to the last mile, going to the communities and engaging the community. And as we do the screening, we're also talking about empowering the population to be with the deaf. Because the deaf population
They are unique in the sense that hearing loss is considered to be an invisible disability. If you look at Mr. Kakiri on my side, you cannot tell he has a hearing problem, but he's totally cut off from you if there were no sign language interpreters. So we want to empower everybody in the community so that they can be able to understand, so that they can be able to learn. And with this, we have various policies and laws that have been put in place, including the Kenya Sign Language Bill of 2021. You can go and look at it. We have other policies that are put at the level of the Ministry of Health. And we have Chai, who has brought together the Ministry of Health, the Ministry of Education and Social Work, so that we can do a multi-sectoral collaborative approach. We work with the individuals with impairments from birth all the way and integrate them into the society. Back on the other side, we also want to empower the deaf population to have culturally acceptable and appropriate screening. The deaf people also give birth to children who are hearing. You learn your language from your parents. So these children who are hearing born of deaf parents, are they able to, what is their first language? Is it sign language? Is it speaking normal? That is total communication using spoken language. And so by going to the community and empowering people, we will be able to create an inclusive environment for them, and they can be one of the lowest lying fruits in creating people, in turning people with disabilities to economically empowered and independent individuals. Thank you.
My next question is to Mr. Ondiege. And from your experience, Mr. Ondiege, in orthotics and prosthetics, what practical steps can be taken to ensure quality and equitable access to mobility-related assistive products, particularly in counties where rehabilitation services are weak or absent? And how can national standards and training support this goal?
I think I have so much to say, but I would want to make it very precise in the sense that when we are now opening up for rehabilitation, and I must appreciate Chai because it is Chai who have brought us together. Even in this panel, I think all these people, we have been together in working towards creating even curriculums for issues of rehabilitation. But I want to be very specific on the issue of prosthetics and orthotics, because that is my main area. And in prosthetics and orthotics, we have been having them in the country since time immemorial. And I think even we started this during the Second World War, the questions of rehabilitation came into being. But when we are talking of rehabilitation, there's a particular profession that I would want people to pay attention to: orthopedic technology. There's orthopedic and trauma technology, and there's orthopedic technology. I think it is a confusion that was brought by KMTC. I saw them in the house, but I'm talking of orthopedic technology. We have done survey in the whole Republic by the help of Chai to help us know how orthotics and prosthetics are provided in the country. And we realized huge gaps. And that is how Chai came in to start supporting. I would say I am a beneficiary directly of Chai because my hospital, Kenyatta National Hospital, have been rebranded, I would call it so, by giving us new machines and partitioning the whole orthopedic technology department into a way that the flow of work is easy. And the devices, Kemsa talked here. And I think through this COG, it should go that everything that is required for a person with a disability should be tax exempted. Especially the materials we are using to make orthotics, the materials we are using to make prosthesis should be tax exempted. I know nothing works well if there are no statistics, but we want to bring in real-time statistics that will help people to identify what we are talking about in terms of rehabilitative devices. As KNH, one of our policies is that we should help other hospitals in planning for what they do. And I am here as a consultant prosthetist orthotist that I am very ready, and Kenyatta has been sending me out even through Chai to try and help other counties to come up with a proper orthopedic workshop that will develop and design and make any rehabilitative appliance that is within our reach for the physical disabilities. You have heard that the category of the physical disabilities, based on the recent bill that was assented to by the president, that disability bill, that 26 categories are on physical disability. That's not a small number. And therefore, we need to work hand in hand, all of us together. And as Chai have started making it, because this Chai is what even helped rehabilitation to make their first strategic plan for rehabilitation services in the country, 2022-2026. And I think a good number of you people were around when we are trying to make that strategic plan to work. And therefore, for that strategic plan to continue working, it is working. But for us to realize every step in that, we need collaboration of everybody. My colleagues have talked here, Dr. Midamo and Madam Mary. I am also a specialist on issues of wheelchairs. And it has always been, because we refer to wheelchairs, they are in the line of the walking appliances. And in the history of the Republic of Kenya, those things are given as charity. We don't need charity. We don't. And that is why Chai came in, and we have developed 11 different curriculums, some of which are already going on in Kenya Medical Training College, JKU Art, and KU for the training of people in different areas. Orthopedic technology have benefited because they have a higher national diploma, and we developed a Bachelor of Science in Prosthetics and Orthotics that is going to take place in Jomo Kenyatta University of Agriculture and Technology, courtesy of Chai through 80 scale. And therefore, I would want to request all of us to think of it this way. Daktari gave example. When she wanted to enter this hall, she had to go round. Why? Because accessibility that can easily be done by us, if we are all concerned, will be there. The thing is, as we are growing old, rehabilitation is for everybody.
Yeah, thank you.
And you know, they normally have a problem with everybody have a problem with reduced activity. Thank you. Yes. So in conclusion, I want it to be a concern of each one of us, knowing that we potentially need rehabilitation. Thank you.
To Dr. Shem Pata from Mombasa County. And Mombasa County is among the counties benefiting from 80 scale, supported optical labs, and hearing devices. How have these investments impacted service delivery, and what policy shifts or budget actions helped make this possible in Mombasa?
I think we've just actually started receiving the support through the 80 scale. But I want to share my experience in the sense that the 80 scale program or project has really reawakened our interest in terms of rehabilitation services as a whole in the county. Now, Mombasa County has around 47 facilities which are spread all over, and rehabilitative services are basically offered within the level 4 and 5 facilities with the different specialities, particularly orthopedic, psychiatry, audiology, and the rest. Now, we know that from the last Kenya Demographic Health Survey that was done, they actually listed that there are almost 20,000 of persons living with disability, with 28% of them actually being visually impaired in Mombasa. However, I think there are a lot of gaps. There have been a lot of gaps in terms of service delivery in rehabilitative services. Key amongst them is actually the prioritization of these services in our plan, the availability of equipment, availability of the assistive devices, and all this. So it was very, very imperative that when this program really came in with the assistive technology scale, that we actually have seen a lot of improvements in terms of the service delivery, and this has also actually facilitated a lot of policy shifts and also budgetary action within the department. Now, we have recently acquired the ABR machine for screening of babies for hearing loss. These services were not available, I would say, the whole of Mombasa County, but we are now able to do early screening for the babies. We are very well aware that if the babies are not actually, or who have hearing loss are not actually screened early and given care, then this might actually impact on their speech development as well as learning. So it's very, very key that we do early screening. So what we have been doing actually with this technology is that all the pediatricians actually now refer the babies to the audiologist, and then the screening is actually being done. Apart from that, we talked with a neonatologist, and now the audiologist actually at least once or twice in a week, every Tuesday and Thursday, visit the newborn unit to be able to actually screen the babies. At the moment, we are also developing some protocols on how to actually screen the babies. Yeah. Other than that, in terms of the visual, we actually anticipate to also get support on this. We have already made a commitment as the Department of Health in terms of provision of the rooms. We have also made commitments in terms of even allocating money to buy the lenses from KEMSA, 4 million. The board actually did allocate this. But other than that, what we have also seen is that the department itself has now also lobbied through, given that now we are getting the assistance from CHAI, to actually get additional funding to be able to actually support the department.
Yes, thank you. Thank you very much, Dr. Pata, on the progress made. And I'll just ask briefly, Mr. Munyendo, how can we leverage on partnerships to ensure that we have access to ATs, rehabilitative services, just briefly?
Basically, we want life-changing partnerships that enable persons with who experience functional difficulties and participation restrictions to attain the highest quality of life. We all know the benefits of working together, but what I want to say is not an event, it's a process, and it all begins from conducting a stakeholders mapping to understand who is where, doing what, and how best we can build synergies. Then through a co-creation process, you identify the various value proposition elements that are brought together by various members of the team. And as usual, you have to go into a teaming agreement, which is like a bond or an MOU, to clarify and to commit on the agenda of transforming lives. And apart from that, you really have to make sure the government is leading from the front. Because by the end of the day, we can't replace the government, neither can we operate outside the government priorities. And after you have done that, it's always good to have a joint review kind of forum. Could be quarterly, could be biannually. But the most important is to deepen the connections and the relationship of working together and holding each other accountable and building more trust. Thank you.
Lastly, I will go to Mr. Kabuchi from KEMSA. And the question is basically you'll just be addressing the supply side. And the question is, given KEMSA's growing role in assistive technology, supply chain management, how is the agency working to ensure reliable procurement, warehousing, and last mile distribution of the assistive products?
Thank you, Dr. Bitok. KEMSA is the national supply chain entity. For us to ensure that we are well aligned with the national priorities, we are aligned to the Rehabilitative Services and Assistive Technology Strategy 2022-2026, as well as the new Persons with Disability Act. For us to ensure that then we have the right products, we have instituted the following as preparatory measures. One, standardization of the products and the scope. We already have a national priority product list, which is currently being developed, courtesy of CHAI. We also have partnered with the Division of Health Products and Technologies at the Ministry of Health. This way, we ensure that we have the correct or the right products because we will be able to be responding to what the need is out there. We have already put in place a fit-for-purpose procurement process where we will be using a multi-year procurement strategy through framework agreements to ensure that we have commodities as and when they are required. In terms of quality, because quality is key, we have aligned ourselves to the WHO specifications, and this is ISO 9999, where we have adopted that, and we are leveraging on the registration and oversight from Pharmacy and Poisons Board. In terms of warehousing, we have a unique fit-for-purpose section within our setup, specifically to handle assistive devices. And finally, when we talk about all commodities, we cannot have commodities without aligning to finances. We are working and we have just signed an MOU with the National Council for Persons with a Disability that anchors our supply chain for assistive devices around and ensuring that we are working together as a sector to make sure that priorities are gotten right. We cannot do all this if data is not made visible and it's not available. KEMSA has a state-of-the-art logistics management information system, which is available to the facilities to ensure that we are correcting consumption data, and we also are facilitating them with the necessary tools to ensure near accurate forecasts that will inform the investments around this sector.
Yeah, thank you very much.
Thank you so much.
Yeah, I'd like to cut you short so that we have time for our plenary. We'll just take a few questions from the plenary, and kindly just feel free to raise your hand. Someone help me circulate the microphone. Yeah, so we'll have the gentleman on this side, and then we have another question on that side, and kindly indicate who you're directing the question to.
Thank you so very much for the session. It was very insightful. I'm Philip Kabur from Homa Bay County Disability Forum. I want to report that access to AT is still very low, especially in Homa Bay County, especially to our very remote villages. Recently, we are doing advocacy on inclusive education. So we were able to travel to very remote villages. There are people who are still crawling on their knees. There are children who are still waiting for wheelchairs to go to school. I have a child
who is 15 years today, who reported to school only last year after getting a wheelchair. So my question is, how can we upscale access to AT? I don't know who will take that one, but somebody has gotten me. Thank you.
Yeah, thank you. So that's one question. How can we upscale access to AT? We'll take one more question, then we can respond to the two together.
Thank you so much. I'm Dr. Wino. I work in the public health space. Listening to all the presenters and the people who have spoken before, from Rosemary to the PS, Dr. Luga, I realize that people know what is to be done, but the gap could be on the implementation. But this is my question. I know the theme today was on assistive technology. I listened, sorry, you'll forgive me if I've forgotten her name, but I want to believe it's from the ministry, from MOH. The panelist just in the middle, I forgot the name, sorry. What is currently being done on the aspects of sexual and reproductive health among people living with disabilities? I happen to have done a small research in Moranga with my student, and it was really, really shocking on that particular aspect of sexual and reproductive health. Even to find out that the very same healthcare providers who are able to, who are probably expected to give assistance to these people, the same very people that has got a very bad attitude towards people living with disabilities. Thank you.
Yeah, thank you. Thank you very much. So I'll request Dr. Moko to respond to the first question.
Thank you. So the question on upscaling access to AT is something that we have extensively discussed in our multidisciplinary team at CHAI. And our strategy is to focus on community engagement. So community engagement, because we know that we need to be able to empower the members through advocacy, to be able to identify and to be able to know where these services are available. In this case, we mean that we want you to be able to screen in time, to be able to be empowered well enough to be able to identify this person has a disability, and then to refer them to the appropriate facilities. When you refer to the appropriate facility, they will be able to get the appropriate AT, which is going to enable them to then transition into either education or to be able to fit into the workplace, envisioning inclusivity. And on the other way around, we are also doing a lot of screening in schools for children with disability to look for secondary disabilities, and also screening in the community to be able to identify. So as we are engaging and promoting advocacy, we are screening, and with this, we should be able to get as many of these people as possible and empower for the people in the community to continue with this screening. Thank you.
Katra, would you like to respond to the last question? Any of the panelists can also add once Katra has made her response here.
Thank you so much. I know you are struggling to mention my name. I'm Katra. I'm from the COG. So mine is to say, like, what we are currently doing is uniform across all over. Like, there is no specific consideration for rehabilitated people who requires rehabilitative service and the rest. So, if there is a policy that has already been developed in sexual, like for example, sexual policies, then that means it has to be implemented across all sectors. And I know, like in hospitals, what we are basically enforcing is like there is a whole unit of gender-based violence and probably even for rape and sexual harassment. And I know any patient or any client who actually come across such are basically reported. Even in the police, we work in collaboration with is it called police officers or what? The Department of Yeah, Polycare. So, like we work in collaboration, and that means we also need to bring on board the community strongly. The community should also be very vigilant around on what is actually happening around the vulnerables, because like you are their person, you are the person who should be also helping them to advocate. So we need to do a lot of community awareness. We need to refer, and we need to make sure that as much as somebody has been affected, we need to find justice for such. Right now, there are so many issues around sexual health, harassment, and people are coming out basically to explain, but probably sometimes you find the inquiries that never come to justice. So what we need to do is basically to put a very strong governance structure that can be able to address this, but we need to have the voice of the community. We need also to work in collaboration with all the key stakeholders that are supposed to address this. Unfortunately, I don't have the figures of probably those who have been affected and those who have not, the issues have not been addressed, but I think we can be able to have side chat, and please let us report. Let us also try to create a lot of sensitization, a lot of awareness, so that these people know their right and where to access such services once they are affected. Thank you.
Yeah, thank you very much, Katra. We just have one question from here, then Henry, because of time. I guess that is Miss Mwaniki. Yes, kindly pass the microphone to her.
Okay. She's saying hers is very hot. Mine is to Katra, and actually is a request that from the COG platform, you see, okay, I don't want to say enforcing, but trying to streamline the guidelines, you see, considering it's now business unusual, is it possible for COG to do a communicate to the counties? Maybe giving attention to the guidelines so that then, if it is the Department of Gender, they don't have to be seen like something is being taken away from them. And you see, and then also the fact that, you see, for me, I can't go anywhere without a device. But in the counties generally, devices is a political agenda because it gives political mileage. And so then you find assistive devices are put in stores for even 6 months, waiting for someone to be the one issuing the devices. But maybe if it comes from the Council of Governors, it gives us a platform to at least articulate the issues to the people concerned. Thank you.
Yeah, thank you. Dr. You also had a question? A comment? Yeah.
Mine is to the gentleman from the Ministry of Education. Sorry, I've forgotten the name.
Mr. Haga.
Mr. Haga. Thank you for what you have enlightened us. When I'm asking this question, I'm coming from a position here. I've once been a board member of the Ministry of Education, Nyeri County, visited several schools. I'm also interacting with the parents of children with disability, and I'm talking about this integration in education. What you have noticed is going on in some of these schools. The children with disability are all dumped in one room. You find in a room where you have autism, mentally challenged, and sometimes some of the ones who cannot hear, the ones who can't see. So instead of being a learning institution, it's actually like a daycare. So the complaint from the parents, which I feel for, is like it's not like they're going there for education. They're just going there to stay for the parents to come for them later in the evening. So the request from the community, I want to be their mouthpiece. Can we have a formal education in these institutions? Integration is good because it's near the community. But can these children really get value for what they have gone to school for, so that they also benefit like other children?
Yes.
Segregate them and provide the relevant teachers for these children. Thank you.
Yeah, thank you. Thank you very much. I think because of time.
Yeah, sorry. I just wanted to respond to my sister. Sorry. I just wanted to respond to the concern. And I think we all need to know that information is power. Sometimes there are things that are happening that are never brought to our attention. And I know, like, there were even assistive devices that have stayed at KEMSA for For close to a year, Bitok, because of some bureaucracy and what. And that came to our attention, and basically COG unlocked it. And I think we unlocked it within a week. So if we basically can be able to get such an information, you don't necessarily need to write to me or what, or write to COG. If you have my number, or you have anybody's health number, or anybody that even within COG can be able to link you up, you can be able to share with us that information, because it is easier for us to basically unlock it so quickly. We'll just do a memo, and probably if it is things that are touching between the two levels of government, we can actually brainstorm on how to quickly unlock it. So we are there, and we are very available, and we don't want us to have bottlenecks in terms of service delivery, because these particular equipments are meant for you. There is no need for it to be locked in a store. I don't know, to be taken to where or to who, when the person who actually requires it is in need. So it really touches us, and we feel that we should work very, very closely with you guys, share information with us, so that we can be able to unlock some of these challenges that comes through. Thank you.
Thank you very much, Katra. I'll allow Fred to respond to Dr. Midhamo's question.
Thank you. I know Dr. was raising an issue which we have noted, myself and the Minister of Education officers in the room. But maybe just to explain that there is what we call the stage-based curriculum. And this targets mainly neurodivergent and those learners with multiple disabilities. And in that curriculum, each individual learner has his or her own lessons, basically. So you might find some of them sometimes seated in the same classroom, but it is the teacher who knows and appreciates the different levels where these learners are. But yes, like I've said, we have noted, and we are going to follow up to just make sure that it's the right thing that's happening. Thank you.
Yeah, thank you. Thank you very much, Mr. Fred. Kindly allow me to just request the panelists that if you have a question after the session, kindly feel free to reach out to the panelists so that they can respond to your question. I'm told that there's another session that you need to go into. So I'll just allow the panelists to just give 1 minute parting shot, then we can hand it over to the next, to Ken to do the communique. Yeah, so 1 minute each panelist, just as a parting shot. Start with Mr. Kakiri.
Okay, thank you so much for this panel engagement. My parting shot, or rather my final message is, you see, always inclusion begins from us, ourselves, from the partnerships that we work together, from the time you begin the design phase, involve persons with disabilities in consultation, so that implementation will be easier. As opposed to beginning a project earmarked to benefit persons with disabilities without involving them, then implementation will pose great difficulties. So normally we do have many policies, laws, or other legal instruments out there, beautifully domesticated on paper, but in reality, implementation matrix becomes difficult. So my plea to all of us is that let us form synergies or partnerships. Let us work as colleagues, so that we copy, how the best practices from CHAI's work, which can really, really assist us to change the society in a way that we desire it to look like. With that, I end my remarks. Thank you.
Thank you. Dr. Moko, 1 minute.
My parting shot is to all of us. Each of us is unique in our own way. And so people with disabilities are unique in their own way. So they're part of us. We should include them. At the same time, each of us are exposed to a form of disability. At any time, you can develop a disability. In your day-to-day interactions with the environment, you can be declared disabled after any event. So investing in disability is investing in your own future. So let us promote inclusivity. Let us support people with disability so that we can have a cohesive society that we will build the economy together.
Thank you, Mr. Kabuchi.
Thank you, Dr. Bitok. I think there is a question which was asked around tax exemption.
Respond to that quickly, yes. Yeah.
Tax exemption is a wholesome process. It starts with the sector making the necessary presentations during budget making, and therefore I would recommend that the sector sits together, identifies what needs to be, tax exempt, and you make the presentations to the National Treasury so that the tariffs can be appropriately, assigned, so that anything that qualifies for tax exemption then will qualify for that. From KEMSA, we are ready and willing and set to support this particular initiative. We want to ensure that as the country works towards universal health coverage, assistive devices will be part and parcel of that solution. Thank you.
Thank you. Director?
Thank you so much. My parting shot will be rehabilitation services must no longer be forgotten. It must be a pillar in our health system. We must invest in infrastructure. We must invest in health-skilled personnel. We must invest in assistive technologies and community-based support so that every person, regardless of their ability, can live with dignity, independence, and full participation in the society.
Thank you. Thank you very much, Director. Mr. Fred?
I think the issue of allocation of resources constantly comes up when we are discussing AT. My parting shot would be that we all have a part to play. We have a role to play. The budget making process that has been talked about is very participatory. And in our own different ways, whatever stations we are in life, if we are able to participate in that budget making process, that public participation stage, we can make a difference in terms of what's allocated for AT. Thank you.
Thank you. Mr. Munyendo?
Okay, thank you. My parting shot is we all have duty to make a difference for others and also for ourselves. And in most cases, we believe we don't have what it takes to make that change. But I'm sure it begins in the mind. So with an appropriate shift in the mindset, I'm sure we can make that difference with what we have. Thank you.
Thank you very much. My parting shot is that counties need to prioritize rehabilitation services by allocating specific resources for assistive technology and rehabilitation, and also by ensuring that the coordinators for rehabilitation are integrated into CHMT so that they can ensure that the plans include rehabilitation. Thank you.
Thank you. Thank you, Dr. Pata. And finally, Mr. Ondiege?
My parting shot is we are all in this business of rehabilitation. Since disability is a club, it is my prayer to all the counties, 47 counties in this country, to be ready to accommodate rehabilitative officers so that we don't have to send people to Nairobi for things that can be done in Homa Bay. Thank you.
Yeah, thank you. Thank you very much, Mr. Ondiege and all panelists. We've had the issues on infrastructure, on human resource, on access, in the education sector. The issues are many. There's work going on, and there's still a lot to be done. But thank you very much, dear panelists. And before I release the panelists from the stage, we have something arranged for them. Yeah. So we'll request Katra to kindly give a gift to all our panelists. So we'll start with the... So I'll also request our presenters. We had the CEO KEMSA who was here. We have Rosemary. If the CEO KEMSA has already left, we'll request someone to pick that for him. So we'll start. Yeah, so Katra will help us give the bags to the presenters. So our first presenter is Rosemary. Let's clap for Rosemary, please. And you're free to choose the clap you want, because we also have people who are visually impaired. So if we do this, they can't see, so you can choose the clap. You can do both this and then a clap. Thank you. Who will pick the gift for the CEO, KEMSA? Okay. Rosemary, I'll call you back on stage to help me give the panelist here. So let's clap for the CEO, KEMSA. Yes, thank you. Thank you very much. Katra, please have a seat. I'll request Rosemary to come and present the gifts to the panelists. They've done a great job, don't you think so? Oh yeah, sorry, I'm being reminded that I left out Mr. Waweru. It's lunchtime, sorry, the glucose levels are low. So kindly assist Mr. Waweru to come on stage to receive his gift. Okay, so let's clap for Samson. Yes, thank you very much. And we'll also, thank you, Samson. We also have Nicholas to receive the bag on behalf, the gift on behalf of the PS. Nicholas, please come in front. So Nicholas is the project manager for ATScale. He's the one who's coordinating all these activities, coordinating the ministry, CHAI, the county, COG. Yeah, so let's clap for Nicholas as he receives the gift on behalf of the PS. Thank you very much. Katra, I'll request you to step down on stage to present the gift to Dr. Midamo and Mary Mwaniki. Cameraman. Yeah, first to Dr. Midamo. Oh, that's Ms. Mwaniki. Yeah, thank you very much. And then to Dr. Midamo. Thank you very much, Director. Asante sana. Thank you. Yeah. So welcome back to stage, Katra. Now I'll request Rosemary to do the honors. We'll finish with Director, so you can start with Dr. Moko. So we start with Dr. Moko from KUTRH. Let's clap for Dr. Moko. Thank you, Dr. Moko. And next is Mr. Kabuchi from KEMSA. Let's clap for Mr. Kabuchi. Asante sana. And Mr. Kakiri. Yeah, we clap for Mr. Kakiri this way. Thank you. Yeah, next is Mr. Fred Haga. Yeah, we clap for Mr. Fred Haga. And then Mr. Munyendo, before you sit. Mr. Munyendo, thank you. The country director, CBM, thank you. And now we have Dr. Pata. Dr. Pata, please come in front. Yes, thank you. Asante sana, thank you. And finally, we have Mr. Ondege, a consultant prosthetist and orthotist, a very hard name. Yeah, thank you very much. Let's clap for him. Yeah, so thank you, dear panelists. I want to invite Mr. Munyendo to present the gift to the moderator and to the chair. So we'll start with the chair, Dr. Marani. Yeah, we clap for the chair. And finally, I call myself.
Well done, Daktari. Well done.
Yes. Oh, yeah, I forgot to pick it. Thank you. So thank you very much, dear audience, to our audience, to our panelists. We really appreciate. This has been a very great discussion. And for any questions that were not responded to, please kindly feel free to speak to any of our panelists to address those questions. And we hope next time we'll have more time because I think the time was not adequate. And finally, I've been told to present the gift to our director, Katra. So I'll request the chair I hand it over back to the chair as
Thank you very much.
Okay, so I want to call Ken to give the communique and also do the vote. Who's doing the vote of thanks? Yeah, and the vote of thanks. Panelists, feel free to exit the stage kindly. Oh, okay. So allow me to welcome Mr. Nicholas Nyamoya, the project manager for ATScale, to give the communique and also do the vote of thanks. So let's clap for Nicholas as he comes on stage.
All protocols observed. Ladies and gentlemen, good afternoon. Good afternoon. Yes, my name is Nicholas Nyamoya. I am the project manager for ATScale Kenya project and also work at the Ministry of Health as the Deputy Chief Occupational Therapist. I'm happy to stand before you and to be part of this very important discussion. One thing or few things that I picked from the conversation, I'm talking about this as he prepares the communique, specifically from the PS, that priorities for government on this space is healthcare financing or health financing on AT and rehabilitation, building capacity for human resource, digitization also is a very important area so that we have a seamless way of accessing assistive technology and rehabilitative services. So I want to bring to our attention that there is always a return on investment for investing in assistive technology. And global AT report on economic value for AT rated that at 9 to 1, which means for every $1 spent, we get $9 in return. Based on that, so it means that we can approach this from very many angles, that when you invest in AT for an individual, it does not only impact on that individual, it impacts on the community, it impacts on the whole nation. Because when an individual is productive, then they are able to support the nation or participate in economic building of a nation. Having said that, allow me to read through the communique. This is based on the discussion that has happened since morning up to this time. And as my colleagues prepare it, so in this deliberations that we've had since morning, we have hereby adopted the following commitments, or we hereby adopt the following commitments. Commitment number 1 is to recognize that assistive technology and rehabilitation as a human right. To uphold AT access as a matter of dignity, justice, equity in the national and international human rights frameworks. The key actors in this is a Ministry of Health, Council of Governors, National Council for Persons with Disability, and the Ministry of Labor and Social Protection. Number 2, we have integrate assistive technology and rehabilitation into universal health coverage. Most of us have already spoken to this. Ensure these services are prioritized. Number 3, Strengthen local manufacturing and supply chain. In the interest of time, I will move with speed. So the actors in this will be Kenya Society for the Blind, KEMSA, private sector, national government, county governments, National Council for Persons with Disability. Then number 4, we have enhanced early identification and intervention. The key actors in this are Ministry of Health, Council of Governors. Number 5, we have build technical and human capacity, that is train healthcare workers, technicians, and educators in provision and maintenance of user support for assistive technologies. Ministry of Health, KEMSA, CHAI, and other implementing partners can be able to support us, including Council of Governors. And number 6, we have adopt standardized specifications and reporting tools, institutionalize harmonized AT standards, data collection, and monitoring systems to improve planning, procurement, and service delivery. Ministry of Health is the key actor in this, KEMSA, National Council for Persons with Disabilities. We are already doing something about this in the AT scale project, and we have already come up with the reporting tools for rehabilitation. And this is going to enable us, and we have integrated the indicators into the Kenya Health Information System to be able to help us to plan better. Number 7, we have foster multi-sectoral collaboration by strengthening partnerships between governments, development partners, civil society, and private sector to scale innovations and reach underserved communities. All stakeholders, including those of us who are here and those who are not here, have been called to be able to support in this area. Number 8 is address attitudinal and environmental barriers. Most of participants here have spoken about this, especially the environmental barriers that we have experienced even when accessing this facility. The key actors here is National Council for Persons with Disabilities, county governments, civil society. I can also say national government is key in this area. Then ensure continuous funding and resource mobilization. Also another very important point. So secure sustainable financing. They underline the word sustainable financing for AT and rehabilitation services, including integration of county budgets and leveraging donor support. This is the key actors in this should be all of us, just to say, but majorly national government, county governments, and development partners. Number 10 is to promote inclusive policy and legislative alignment. So harmonize health education. I'm glad KMTC is here, and they have been very key in supporting this area of education. Infrastructure policies to ensure coherent and mutually reinforcing support for persons with disabilities. So the legislature, Ministry of Health, Ministry of Education, National Council for Persons with Disability are key in this. So the call to action is this. We call upon the national government and county governments to prioritize assistive technology and rehabilitation in policies, budgets, and service delivery frameworks. Number 2 is for development partners and donors to align funding with national strategies and strengthen local capacity. Number 4, we call upon private sector and innovators to invest in locally appropriate assistive technologies and inclusive business models. Number 4, civil society and advocacy groups to hold duty bearers accountable and amplify the voice of persons with disabilities. And lastly, for all stakeholders to work collaboratively to ensure that no one is left behind in accessing the tools, the services, and opportunities they need to thrive and to live independently. Together, we affirm that access to assistive technology is not charity, it is a right. We commit to turning today's discussions into sustained action for a more inclusive and equitable Kenya. Thank you very much. Someone said amen, and I also say amen. Yeah, so having said that, I want to request Director Katra to come and move us with the vote of thanks. Thank you very much.
Thank you so much. Good afternoon once again. Good afternoon. Hello. First of all, I want to appreciate all of you. Just say high five to your neighbor. High five again. We must make changes in this country. Say after me, we must make changes in this country. Rehabilitative services should no longer be a begging item. It should be a pillar in health system. Rehabilitative services should be a pillar in health system. Today you are here, tomorrow you may not know where you are. I had a friend who was just like me. He was my very close cousin. And during campaign in 2007, he went to Mandera County. He wanted to go and vie for a political position. Unfortunately, he came back on a wheelchair. He never thought that one day he will also go to that wheelchair, right? So we never know where we will be next. It is only God who plans our lives. And disability doesn't mean that it is inability, right? So let's make sure that we all work together, and let's make sure that at least when they need us, we are available and services are very available for them. And thank you for sitting through. I know people are moving to the main plenum, but because of the importance of this side event, you felt that we should sit through, listen, and make change. So I'll quickly read through the resolution, and as I said earlier on, I will just ride on the established protocols. Today marks a new dawn in advancing equality in Kenya. It has been both an honor and privilege to sit with you and engage in meaningful dialogue on the future of assistive technology in this country. On behalf of the Council of Governors, I sincerely thank Clinton Health. They've worked with us. They've really worked with us. Anytime we reach out to them, they are very available for us and they assist us. I also want to recognize the presence of the CBM, Mr. Muyendo. Anytime we have such a problem in terms of assistive rehabilitation services, we reach out to you and you come in handy, and we really appreciate you, and we don't take that for granted. So it is with their steadfast effort in addressing the needs of our communities, our partnerships such as this between government and committed development partners are essential in driving impactful, sustainable change. I also extend a deep appreciation to the Ministry of Health for their leadership. I really hijacked PS Oluga. He was also in another side event. And apologies from the CS who was supposed to be giving us a keynote address because of other competing activities. He had to leave yesterday and delegate it to the PS. But we really thank their leadership for coming through. As we move forward and in line with the resolutions from today's meeting, it is vital that we remain committed to sustainability, inclusivity, and equity across the counties. Let us ensure that no one is left behind in accessing the tools, and support the need to live dignified and empowered lives. I wish to acknowledge all stakeholders present here, the Ministry of Education, who was with me in the panel, and thank you for speaking so well. Today, especially for those who work with us and also those who work with us this journey, the participants also who have joined this side event, out of interest or in search of knowledge, the lessons we take from such forums leave a lasting mark on our work on daily basis. I urge all of us to work together in implementing the resolutions of this side event jointly, purposefully, and also as one team. Remember, having such a powerful call to action is one thing, but implementing or putting the actions into talk is also another thing. And I hope with our collaboration between the partners and the two levels of government, we can be able to basically implement this. And not everything will require resources. There are things that actually require soft intervention, which I believe when we hold on to each other, we can be able to deliver. Asanteni sana na Mungu awabariki. Today is the last day of Devolution Conference, and we celebrate you for actually having that commitment of sitting through up to the third day. And I know the inputs that you've given us from the floor wards, and we can be able to consider and put in the communique. I know some of the action points also that came from here will find itself, at least 2 major points will find itself in the communique, which is going to be implemented jointly. Asanteni sana, Journey Mercies, as you go back home, allow me to hand over to the moderator to close, maybe call upon someone to pray for us, and let us also appreciate the moderator. Mpigeni makofi. I know he's expecting the big club, but this one is different. So I think you've seen, and thank you so much, and thank you everybody. Please, when you go back home, tell other people who have not gotten this opportunity what really, how you are inspired to participate in Devolution Conference. Encourage them so that they come after 2 years for a Devolution Conference. Venue to be told maybe after 1 year. Thank you so much.